everyone. I wanted to welcome everyone to our webinar on building bioethical AI from the ground up. Very excited today to welcome Kelly Michelson, who is IAIM's Chief Ethics Officer, as well as Director for the Center for Bioethics. Bioethics and Medical Humanities. And then we also have Faith Summersett Williams, who is an assistant professor of pediatrics at Northwestern. She has joined as a psychologist and currently works as a behavioral scientist at the, I can't even pronounce, Potomac Division of Adolescent and Young Adult Medicine, as well as at Lurie Children's Hospital. So I'm going to turn it over to Kelly to start the webinar. And then in the meantime, if you have any questions as she's talking, and we'll hold the answering of the questions till the very end, but feel free to use the Q&A, put questions in there, and then I will present those to Faith and Kelly at the end when we have our Q&A.
Great, thank you. Thanks so much. So we've already challenged you with our names and where we're from, but I am looking forward to talking with everyone. Let me pull up my slides. So give me just a second. Okay. Can someone just double check that the slides are looking okay?
They look great.
Okay, sounds good. All right, great. Well, thank you so much. I'm excited to talk with you all today a little bit about some of the ethical challenges associated with AI in healthcare. And just to kind of give you, let's see, okay, a few disclosures related to some grant funding that I just wanted to acknowledge, but I'm not going to be discussing off-label or investigational use products. So our hope is that by the end of the hour, you will be able to describe the use of AI in healthcare, at least some applications, that you'll be able to discuss some of the ethical issues associated with healthcare AI, and describe some potential challenges to AI that is developed for real-world healthcare applications. And the way we're planning to structure the next hour is to kind of give you a few examples of how AI is already being used in the healthcare setting, and then focus a little bit more on some of the ethical issues that AI brings up in the healthcare setting. And then we're gonna, the latter half of the conversation will relate to thinking about AI and some of the ethical challenges related to two specific use cases, and intentionally have identified cases that are sort of kind of thought experiments and or in various stages of development, which we're hoping aligns somewhat with people who may be listening to this conversation, teams who are working on your project. And really, ultimately, our goal is for you all to start to be thinking about these things as you're developing your projects and your technology from the very beginning. And I'll kind of touch a little bit more on that as we go through. Okay, so that is the plan. So I know this is probably a bit redundant for many on this call, but just to kind of set the stage for what we're talking about, I put up a couple of definitions of artificial intelligence, which, you know, we talk about AI, that's what we're talking about. And obviously there are more than these, but I think these are sort of generally good definitions. They are, artificial intelligence is defined as computers that behave in ways that previously were thought to require human intelligence. Or another definition is a branch of computer science involved with the development of machines that perform cognitive tasks that would normally require human intelligence. And again, this is probably review for many on this call, but just to acknowledge that there are a number of different types of AI, and that these different types that I'm just going to allude to are, this is not by any means an exhaustive list, and it's also to acknowledge that these are overlapping. So people will talk a lot about machine learning, which is really how statistical models can be developed to improve their performance over time without necessarily programmed instructions. And then deep learning, which for a non-technological person like myself, I often think of deep learning as like machine learning on steroids, but it's sort of a more complex form of machine learning that can use images or speech recognition, but essentially these neural networks and layers of variables to create technology and solutions. There's natural language processing, which is the ability to extract or generate meaning from text. And it's typically what's used to develop voice-based interfaces or virtual assistants like chatbots. And then there's also computer vision. So the ability to extract meaning and intent out of visual elements like faces or objects, scenes. And this is what we see like in our smartphones and that sort of thing. And if you think about how AI is used in healthcare, there really are a plethora of ways that we're already seeing AI in healthcare. And I'm kind of just listed a few things that I'm going to touch on here, and we'll kind of dig more deeply into some of them as the hour goes by. But one use for AI is to identify risk in a particular population. And we're going to talk a lot more about risk prediction towards the end towards the end of my discussion, when I talk about one use case. AI is being used for monitoring health-related physiology data and other things. We see this in like watches that can identify arrhythmias or monitor heart rate, that can assess people for fall risks, or even alert hospital staff that one of the patients is developing sepsis by assessing their vital signs in real time. We've seen AI being used for treatment. So looking at ways it was used actually during the pandemic to try to identify pharmaceutical treatment. It's also used to like identify when drugs are interacting with one another inappropriately. We see it in therapy. So there's a lot of development of bots for mental health issues, as well as other things. And I'll touch on that again as we go forward. Prognosis, and we'll talk a little bit more about that later too. We're even seeing AI being used to write, whether it's writing like manuscripts, research manuscripts for publication or other forms of writing. We're seeing that both in the healthcare setting as well as in the popular sort of outside the healthcare setting. There's even been AI generated or developed to do ethics consultations. So actually to take data from patients' records and make recommendations around a specific ethical question. We're seeing it being used for education and for diagnosis. One example of diagnosis is using AI to identify breast cancer in mammography in mammograms. But like this has been splashed, I don't know what the right word is, all over the media in the last, couple of weeks with the advent of ChatGPT. And some of you may have been at the talk last week about it. But among the many things that ChatGPT has been described as being able to do includes making medical diagnoses. So there's no question that AI and healthcare is upon us. And the likelihood is that it's going to continue and even expand. These are projections from 2019 about the money that were anticipated to be invested in healthcare related AI by the year 2026. And you can see these are different ways in which AI is involved, but like these are numbers in the billions of dollars. And if you just look at the sort of top 10 applications of AI in healthcare, you'll see these things here. So anything from robotic assisted surgery to nursing assistance to helping with workflow in a clinic setting. I mentioned diagnosis. You can see towards the bottom, preliminary diagnosis, and even automated image diagnosis, which I mentioned using for breast cancer detection, has also been used for detecting COVID from x-rays. So a lot of applications in the healthcare setting. And with all of these applications, I think it's really important to think about where the balance of benefit and burden comes. We've talked about a lot of sort of the public health benefits to the healthcare system, the money that's in AI. And I think that really sort of definitely tilts the scale towards the value and benefits of AI. But I think we also have to think about where does the individual sit in all of this, and what are the issues, and how can we make sure that the individual is acknowledged and represented in a way that's ethical and appropriate. So if you think about the different ethical dimensions of using artificial intelligence in healthcare, there really are a number of them. And just to kind of give you a quick overlay of that, this is just kind of a list of some of the things that people have been considering in terms of some of the ethical challenges associated with AI in healthcare. And these vary anything from human agency to some of the privacy issues around data governance, diversity, non-discrimination. And I know that those people on this talk who are developing projects are specifically thinking about some of those issues. But there's also issues related to how are we informing patients about the use of this technology? How does it engage in how we educate people in healthcare, and what are the implications of that? Malpractice, safety. So a lot of these things are happening. And obviously I can't touch on all of these, but what I was going to do is kind of touch on some things that kind of loosely fit into three big categories that I think you can break down when you're considering AI. And one is those issues around data, which for most AI is really the fundamental kind of building block. Some of the issues that are relevant in terms of how that data gets processed and how the technology is developed, and then thinking a little bit about application. And as I said, there are a lot of different issues to consider. And so I'm just going to kind of touch on a few things in each of these big categories. So I'm going to start with data. And one thing that I think is really important to keep in the back of our minds when we think about data and the use of data in our time is that it has undeniably become perhaps the largest commodity that exists in our society. And sort of this slide is meant to show you that that has changed over time, with the 19th century steel being sort of the huge commodity, and that kind of transition to oil in the 20th century. And now it really is data. And just to kind of push that point forward, in 2019, 7 of the 8 largest companies in the world were active in data. So I'm referring to companies like Microsoft, Apple, Amazon, Google, Facebook, Alibaba, Tencent. These are all companies that are making huge profits with data. And I alluded to predictions for how much money there is in AI in healthcare. And I think that that is reflected in real time in this slide that demonstrates explosive financial growth. And part of that is related to data. We're even seeing healthcare institutions trying to reap some of the rewards of their data. And these are just some headlines from stories in the last few years about different healthcare organizations that have been partnering with companies that are operating in big data and sharing their healthcare information with these organizations. And this becomes particularly challenging even when a healthcare organization may share what they consider quote unquote anonymized data to a technology company because for a couple of reasons. One is that with the advent of the vast amount of technology that exists today and tracking, whether it's on your cell phone or your watch or whatever it is, the ability to actually de-identify what is thought to be anonymous data is very real and happening and has been demonstrated. And the other reason that this is important is because while healthcare organizations are obligated to protect their patients' privacy and are have to align with HIPAA, for example, other organizations like Google that are not delivering healthcare are not obligated to those same regulations. And so the legal landscape around sharing data is sort of very much not necessarily protecting the individual patient who goes to see their clinician. And that privacy piece is really important when it comes to healthcare. First of all, many view privacy as a fundamental human right, but there's something really important and different about what patients, individual people view and how people view privacy when it comes to their interactions with their clinicians and their doctors. It is sort of long been thought to be a safe space that you can share anything and everything about yourself. And so that trust is really important. And when we see data sharing of information that may potentially be de-anonymized, that could be concerning for some. The other bit around this related to privacy and also data sharing is sort of back to some of the financial pieces, and that when an individual person's information is shared to a company that's going to use that data for profit, who gets to reap those financial rewards? The organization, the healthcare situation, the healthcare system, or the patient. And while I think this is a little bit different than what we've seen previously, I think the story of Henrietta Lacks has some application here. And for those who may not be familiar with this story, Henrietta Lacks was an African-American woman who had, I believe it was cervical cancer. And she went to her doctor and she had her cancerous tumor cells removed. They actually tried to remove it. She eventually did die of her cancer, but unbeknownst to her, without her permission, they took her cells and grew them up in the laboratory. And it turned out that for whatever reason, her cells were unique in that they could be grown sort of ad infinitum. And ultimately, Henrietta Lacks' cells have been sold to research laboratories all over the world and have been the foundation of numerous different discoveries in healthcare, as well as have provided financial benefits for different organizations. And this all without her permission and without her obtaining any of the benefits of any of this work. And while you might argue that a person's cells are different from a person's data, essentially that's what's happening. And I think as a society, we need to consider where are the balance of what belongs to us and what doesn't. So what do people think about this idea of using data? I thought it might be interesting to give you all a little bit of empiric information about this. And this is a bit of an older study, but essentially what they did was they asked patients who had different medical problems, and that's what's listed up at the top of this slide. These are sort of the groupings of kinds of medical problems the patients had who they spoke with. So patients with cystic fibrosis, sickle cell disease, diabetes, HIV, breast cancer, colon cancer. And they asked them first, do you think that a computerized health database is a good idea or a bad idea? And when they asked people this sort of general question, what they found was that about half and half thought it was, well, actually, let me take that back. More than half thought it was a bad idea. So there's just sort of some general concern, but a fair number thought it was a reasonable idea. And then if you kind of hone the question in a little bit and ask the same people if they thought a secure health database was a good idea or a bad idea, then the numbers start to flip with more people thinking it's a good idea. And if you ask them if they think an anonymous database is a good idea, then even more people sort of flip and think that it's a good idea. And one of the lessons that I take from this is that, at least in this group of patients, and whether or not it can be generalized, I guess I don't know, but that there is, at least among some, this idea that it's okay, it's good that we all share our data for the greater good, for the advancement of medicine and society, and even potentially public health. And but that it's really important that in the middle of that, I, as an individual, cannot be identified. And so that's where all of the people working in technology and thinking about how to manage some of these issues related to privacy from a technical side of things is really important and crucial. And we've seen, I feel like the pandemic has brought to light so many things, but I think one of the things it's brought to light is like the huge value on a global level of having people's data. And this is a slide shot, a screenshot of a dashboard somewhat early in the COVID pandemic, when these numbers were starting to change. And obviously, eventually this screen would have been covered in red. But what I want to acknowledge is that all of this red represents individual people's data. And so there's huge value to the data, and we saw that play out in real time. But there's also challenges in the data. So I'm going to talk about some different aspects of bias that we see in medical data. One is systematic errors that come from errors in practice. And so this is when, for example, a patient's is a particular characteristic unduly influences a diagnosis. We've seen this, for example, in identifying breast cancer, and that there are a higher rate of false negatives in patients with minority or ethnic background. So this is the idea that just because you have a particular background, your data would be erroneous for some way. And this can happen intentionally, and it can also happen unintentionally. And then another challenge with the data that we get from healthcare is that it may not always represent all populations. And when there is systematic underrepresentation of a particular population, that gets reflected in the technology, which we'll talk about here in a second. But we know that elderly people, ethnic people, people of different ethnic minorities, women are often underrepresented in these data sets, and that the data sets often that are collected in mass during routine healthcare delivery may also not represent the population. We know that some populations use healthcare less than other populations, particularly racial minorities or those of lower SES. And so if access or utilization of healthcare is different than the data that's being used to create these different technology is different. This is an example of why this is really important. So this was an organization that wanted to identify patients who are at risk for having severe disease so that they could connect those patients with case managers who could help them navigate the healthcare system. So reasonable goal. And so they created an algorithm to do this. And what they found eventually was that race had a significant impact on whether or not the algorithm identified the person as being at risk for severe illness. And in particular, people with Black people were shown to be less at risk. So if you had a white person and a Black person who both had the same medical problems, the white person was identified as at risk and the Black person wasn't. And so the white person had access to these case managers that the Black people didn't. And ultimately, what they found out was the reason that this was happening was because the algorithm was tied to cost data, and cost data was tied to healthcare utilization. And this particular population of Black people used the healthcare less. And so that was reflected in the algorithm. Another way data sets can become biased is programmer bias, whether when they're deciding which variables to include and how to weigh those variables. And then it's important to note that unbiased data also has problems. So if you have a rare disease, then the number of the patients with that disease may be so small that they're not actually able to build algorithms that are reliable. So data can have a lot of challenges associated with it, as can the process. And I don't need to spend a lot of time with this audience, but we know that data serves the foundation of many of the developing these technologies. So typically taking training data sets, creating some kind of algorithm, and then validating it, and then testing them on another data set. But what's really important here is to understand what's actually happening in those algorithms. So when you come to this process with a goal, and then you use data to create the algorithm and test a new algorithm, that's kind of what I just said. What we've realized is that if we don't really understand what the algorithm is looking at, we can miss a lot. So this is an example of creating an algorithm to identify moles that were cancerous. And they created this algorithm and they found it to be incredibly accurate. But when they dug deeper into what the algorithm was actually using to make the determinations of malignancy, what they found was that there was a ruler in the images of those moles that were cancerous, because the clinicians were trying to measure them for documentation purposes, whereas in those that were benign, they didn't have it. So it wasn't that the algorithm was determining malignancy based on the mole, but based on these other characteristics. So it's really important that we understand what's happening, because if we don't understand how the algorithm is making determinations, it can be fraught with bias and challenges. And the example that I gave around identifying people with risk for severe disease is one. So what I'm trying to demonstrate is that these things sort of build on one another. If you have societal inequalities, those get baked into the data, and then people are represented in a skewed manner, which then serves the foundation for models, which then create predictions or decision patterns that continue to cause unfair treatments and unfair outcomes that then impacts people. And this becomes kind of a cyclical process and problem. And then I want to talk just for a minute before we sort of dive into some of the potential applications and sort of ways to think about these issues in advance. I want to think about the clinicians and the impact on actually the clinicians. And I think it's important, again, to note some of the positives here. So AI has a lot of value in terms of efficiencies when it comes to actually delivering care. I put some example up here related to radiologists and analyzing X-rays and that it would take this particular technology 18 minutes to do the same work that it would take expert radiologists something like 2.5 to 3.5 hours. So there's huge value at the bedside in terms of efficiency. There's the potential to reduce human error, and there's even the potential to address workforce shortages. So this is particularly relevant when it comes to mental health. So I mentioned chatbots previously, and chatbots are one way that are being used to help support management for people with mental health problems. This is important because there are huge swaths of people in the world who don't have access to mental health care professionals. According to the World Health Organization, half of the world's population lives in a country with less than one psychiatrist per 100,000 people. So in those places, having technology in place could be huge. But we also need to think about the difference between being treated by technology versus being treated by a human being. And when you ask people where they want the human to live in this space, I think what you'll find is that people are not quite ready for the human being, the clinician, to completely come out of the space. As an example, this is some data asking people about having a clinician involved in discussion about radiology or a radiographic finding that was assessed by some kind of technology. And what you found in the sort of the top scoring reactions is that people said when discussing the results of a scan, humans are indispensable. That was scored very high. I think the top score was 5 here, and that getting results involves personal contact. So I think people, at least in this study, were expressing the importance of having a person involved. That's reflected in this quote, which I really like, which also relates to radiologists, but I think could relate to any clinician, which is that AI won't replace clinicians, but clinicians who use AI will likely replace those who don't. And so for those of us who think about like decision-making in the clinical setting, we've seen a lot of changes in that process over the last century, from a place where it used to be that you went to your doctor and the doctor told you what to do, what was going on and what to do, to many people would suggest that our healthcare system has moved more towards a shared model where patients and doctors are sharing information across back and forth to one another and hopefully making more collaborative decisions. I think ultimately those decisions are going to include not just clinicians, but also AI. So what I'm hoping that you're gaining from this is that there is a lot going on in healthcare, and there are a lot of ethical challenges. And as people thinking about this, we need to like almost catch up to what's already going on. And so I'm going to spend the next few minutes, and then also Faith will sort of start to think about how we can, instead of running after the train, try to get on the train before. And the idea here is that we need to have the frame of all of the ethical challenges that a particular technology might create when we start to even conceptualize how technology might be used in the healthcare setting. And then with each of these stages, conception, development, calibration, initial implementation, and subsequent implementation, we need to be revisiting all of these things. So it's not just one and done, but it's really a part of the whole process that happens at the beginning and in an ongoing way. So to exemplify that, I'm going to share some thoughts about one use of AI in my clinical setting. I'm a pediatrician. I work in the pediatric intensive care unit. And I'm going to just think about this idea of whether or not what are the challenges and ethical issues or things to consider if we wanted to create a prediction model that would predict mortality in the pediatric intensive care unit. Why would this be important? There are actually a lot of reasons to think about creating these kinds of models. First of all, it's a measure of care quality. It can be used in research to identify cases that may be appropriate for particular research. It can impact management plans, how we talk to families about care, whether or not to embark on different therapies. And for some people who death is either unavoidable or highly likely, there are even considerations around donation of organs. Currently, we have a couple of different ways that we try to predict mortality in the intensive care unit, but those strategies are limited because most of them use admission data. So it makes it more difficult to assess over time as a patient is in the intensive care unit for many days. They're less accurate for people who have been there for longer, and they're not necessarily applicable to the individual patient, but rather to larger groups. So in addition to what I've just described about why I think this could be an important application, the fact is that it's already happening. So just a couple of examples. This is one group trying to predict mortality in the PICU using a neural network model. This group looking at death after a terminal extubation for those people considering donation after a circulatory death. This is an effort to predict death for patients with coronavirus, and this was a lot of the discussion when we were thinking about utilization of scarce resources and how we should allocate scarce resources during a pandemic like Corona, and even people thinking about this in the war zone. So at some level, we're already still running after the train, but what I'm hoping to do, at least for this use case, is give you an idea of how we can think in advance. So I'm going to kind of go through some of the technical considerations, the clinical considerations, and some organizational issues. And my argument here is that we need to be thinking about all of these things as the technology is being developed. So we already mentioned some benefits related to efficiency and accuracy, having real-time information, and even mitigating bias. But it's important to acknowledge that there are potential challenges with this application related to what we know that may be in or missing from the data. So what do we do about deaths that don't happen in the PICU? So a patient who is very ill and the family decides to move the patient towards hospice care, leaves the PICU, which might be considered a patient that didn't die, but then went home and died shortly thereafter. We know that I've already talked about diversity issues and how bias in the data can reflect larger systemic issues. And those are things that need to be considered up front. We know that, for example, minoritized populations tend to find their way to the PICUs more commonly. And so how does that impact the data and the algorithms that we might generate? And I've already sort of talked about this particular study. And so when we are developing this technology, which seems to be already being developed, we really need to think about what is in the black box, what does the algorithm say, and what's driving the decision making. In terms of thinking of some clinical considerations related to this, there are some benefits that are important and that drive the rationale for developing this technology, including if we know which patients were likely to die, we would be more inclined to encourage families really to focus on comfort care, which we know actually can prolong life in a patient who has a life limiting condition. It would give us an opportunity to perhaps maximize in more effective ways sedation and pain control. And for those who are predicted to live, one can imagine that we might more actively pursue high risk and intensive therapies, and even support the use of therapies that can come with very difficult side effects like stem cell transplant. And one might even argue that this could decrease decision-making burden for families if they're, so many times as clinicians, we don't know, and families are left in this sort of nebulous place of making hugely impactful decisions with limited data. The other challenge is that it could actually limit how our medical knowledge advances. And so this is what I mean by this is that if we have technology that predicts mortality, and we then encourage those patients and their families to pursue comfort care, and they go on to die, we're at some level creating a self-fulfilling prophecy. Whereas in some of those cases, we might have advocated for more aggressive therapies that we might learn things from that could advance science and help people survive longer. And then there's this piece about trust and how much clinicians actually trust AI and how that can impact their conversations with families at the bedside. I'm going to do this really fast because I want to make sure Faith has enough time, but we have to think also about some of the organizational motivations and incentives for introducing these technologies, as well as legal issues. So what happens for clinicians that follow what the AI said and the AI may not be correct? And there are some challenges around that. But I'm going to stop because I want to give Faith some time. So Faith, I am going to stop sharing my screen and let you take over.
I'll start. Hi, everyone. My screen up. Thank you so much, Kelly. Everyone, I'm Dr. Faith Summersett Williams. I'm trained as a pediatric psychologist, and I work as a behavioral scientist at Lurie Children's Hospital, specifically in our division of adolescent and young adult medicine, where I lead the research program for our substance use and prevention programming. And so today, I'm going to build on what Kelly discussed, but really focusing on the ethics of justice. And because health justice is at the core of everything I do and drives my discussion today, I thought it will be helpful to ground ourselves in the common definitions surrounding health equity and justice. And so some of you may be familiar with this visual or others similar to it, where equality, equity, and justice are depicted here. And so when we start, we think of inequality as unequal access to opportunities, right? And so then equality is when resources are evenly distributed with the assumption that everyone will benefit from the same support. We've moved along from that to equity, right? Where resources are then customized to address inequality. However, this is often viewed as a deficit-based model where adjustments are made at the individual level instead of at the structural level. And so that's where justice comes in. And it's fixing the structures that produce the inequities to begin with, so that custom supports and accommodations are no longer needed. So I want us to keep this in mind as we continue our discussion today. When we think of pediatrics and the population that I work with at Lurie Children's Hospital, an increasing number of youth live with a chronic illness. And as you can imagine, the management of their medical conditions, in addition to the stressors of normal adolescent development, can exacerbate mental health symptoms such as depression and anxiety. And so oftentimes, some of these youth start to use alcohol and other substances, such as marijuana, and they're using these substances at levels equal to or even greater than their peers without these chronic conditions. And so when we look at specific statistics, approximately 33% of adolescents with chronic conditions binge drink alcohol and 20% use marijuana. And those who engage in alcohol and substance use are at an elevated risk for adverse consequences due to their underlying medical conditions. And these increased risks support the importance of integrating screening services into pediatric hospitals or pediatric primary care settings, where many adolescents with these chronic conditions interface with the healthcare system for their medical treatment. However, few hospital-wide solutions exist that comprehensively and reliably identify alcohol and substance use in pediatric settings. And the number of alcohol and substance use related hospital visits continues to grow, especially among the pediatric population. And these hospital screening rates for substance use remain low, despite recommendations from federal agencies to implement screening tools into standard practice. However, screeners can be built into the electronic medical record, but implementation efforts are often fragmented, and they require additional staff training and time, as well as capacity for staff to administer the questionnaires and then also describe questionnaires to patients, because oftentimes patients have a difficult time self-reporting or understanding some of the screening measures. Also, when screening does occur, it occurs in the unstructured notes in the EHR. And so this leads to inconsistent and unstandardized reporting procedures, and that makes it more difficult for analysis. And so as a result, screening adherence remains very low or pretty much non-existent within many pediatric health systems. And so automated solutions could potentially bridge this divide. So an automated tool that runs off the notes collected during usual care could enable a full screening effort on all patients in these pediatric settings that I mentioned. And this approach would address the issue of alcohol and substance use data that are captured in various places in EHR that can be difficult to mine and analyze. And then AI technologies such as natural language processing and machine learning can be used to train models to identify relevant findings in the notes to then automatically screen patients with alcohol and substance use descriptors. So automated data-driven solutions with natural language processing can analyze the free text and extract semantics from that free text. This process can capture important features from the unstructured format of clinical notes that can be fed into machine learning classifiers for phenotyping. And so this comprehensive and automated approach to alcohol and substance use screening in pediatrics using methods in NLP and ML could offer key opportunities to augment clinical workflow and improve patient care. So there are not many studies published using AI in the context of pediatric alcohol and substance use. However, one recent study published in 2021 integrated logic rules with natural language processing and machine learning technologies to detect substance use information from both the structured and unstructured EHR data fields. And so this study found and helped improve detection capacity for alcohol and substance use among pediatric patients using these technologies. And so some strengths from this model that were identified included a reduction in clinical decision redundancy for providers, as well as alarm fatigue. On the flip side, another recent article published last year found that racial bias and transmission of stigma are often recorded in the medical record. And this is something that Kelly talked about at length, right? And so more specifically in this study though, it found that Black patients at an urban academic medical center, very similar to our setting, had disproportionately higher odds of negative patient descriptors appearing in the history and physical notes of EHRs compared with white patients. And so this bias was captured at multiple levels. So it's evident that it was captured at the individual provider level, but also the implicit racial bias was embedded into the broader beliefs and attitudes maintained by the healthcare system. And so this bias has the potential to stigmatize, racialize Black patients and compromise their care. And as you can probably guess, this article raised concerns about systemic racism embedded in healthcare systems and how AI can perpetuate that oppressive system. Similar as well to what Kelly discussed when thinking about using AI in the context of pediatric alcohol and substance use detection, these AI models using machine learning to support clinical decision-making, or even using these models when trending population health, they're prone to significant and alarming levels of bias. As we screen for patients, we want to be mindful as well that pediatric patients needing treatment for the alcohol and substance use are restricted by the availability and cost of treatment services. And so with these AI models, although we might improve screening, a gap for treatment services, treatment capacity, and efforts to reduce treatment stigma are still needed. We need efforts to reduce these gaps. And then another thing to note, as drug markets evolve, additional model updates might be needed to account for demographic and consumption changes. And so to be mindful of time, I just wanted to briefly go over some suggestions for the future. And I think about suggestions for the future in 3 areas. And one is structural and societal biases, how we can confront that. Oftentimes we think about bias in the terms of equality and equal distribution, similar to the first slide that I presented, right, with that figure. However, I oftentimes challenge folks to think about the underlying foundation. And specifically in the context of AI, I ask questions related to, why does a task or model exist in the first place? Who creates it? Who deploys it? Who deploys it onto which population? And why that population? And then who owns these data and how is it used? And so the root of these problems is not only technological, right? It's really rooted in societal systems of oppression, such as isms and phobias. And so when using technology with this underlying social foundation, it often advances the worst possible things that are happening in our society that are reflected in these isms and phobias. So in order for technology not to do that, we have to work on the underlying foundation as well. Oftentimes as researchers and scientists, we can't just close our eyes and say, I'm a scientist, so that means I'm objective and the context doesn't matter. Instead, we have to understand that science has a bias of seemingly objectivity, right? But we have to understand the dynamics of the social world that is completely subjective in order to make scientific advancements that promote equity and justice. In the third area, bias in the data, for categories that we talked about, like age, race, gender, the solution is really to sample better so that you get a better representation in these data sets. But you can still have balanced representation and still send very biased and oppressive messages. So this is where having diverse perspectives at the table is important for checks and balances when interpreting data and also checking for levels of validity. And then the third area, bias in algorithms, leads to continued inequity because algorithms can amplify the bias that's embedded in data. So we want to be thoughtful about how we actually build these systems and how we can inclusively code and develop inclusive coding processes. So inclusive coding typically starts with people. So who code matters. And so I challenge everyone here today to ask yourselves, are we creating full spectrum teams with diversity of perspectives and backgrounds? So that we can check each other's blind spots. Also on the technical side, how we code matters. So are we factoring in fairness as we develop the program or the systems? And then why we code matters. We have an opportunity to really unlock greater equality and justice if we as scientists and providers make social change a priority and not an afterthought. And so to move towards change, we can work towards building flat platforms that can identify bias by collecting people's personal experiences as the end users of these AI technologies within healthcare. And then we can also audit existing software. Then also we can have inclusive training sets to help developers test these models before deployment or implementation. And then lastly, we want to make sure that we're thinking about the social impact of the technology we are developing. And so the last piece I wanted to call attention to is on the picture on the right is a cover from a very powerful documentary on Netflix called Coded Bias, which features scientists at MIT who expose prejudices and threats to civil liberty in algorithms and artificial intelligence. It's a really very captivating and does a really great description of some of these issues that Kelly and I brought up today. So I really wanted to make sure we had time for questions, and I really appreciate everyone being an attentive audience.
So there are a couple questions that came in during the course. One of them is from Rufus, asking have you seen resistance in adopting AI machine learning solutions in healthcare from clinicians, patients, or both? If so, on what grounds do they object?
Yeah, I can try to address that, and I think that I think there was another question in the chat that had a similar resonance related to that. I think that as we're seeing more introduction of AI, we're going to have a better sense for this. in my setting, for example, we do see sort of like automated triggers for things like sepsis. So, you know, this is happening, but it's kind of, I would say in some settings, a little softer than in other settings. The resistance that I think that, at least for me, I guess I should speak personally, is really related to some of the things that we're talking about here, in that it's so hard to you know, to know why a particular algorithm is choosing what they are. And without that, I think that's where some of the resistance comes. If we can't explain it, how can we trust it kind of perspective? And that's where I think what I think Faith and I, one of the points Faith and I are trying to make is that because there is a concern about that in the community, and I think among clinicians too, it's important for developers of AI to demonstrate things up front that will help clinicians feel more comfortable with it.
Okay. So another answer, I think Gerald had actually two different comments. One is, you know, when you were talking about examples of where AI machine learning is being used, he commented, what about preventative care with personalized diet and exercise plans as an example? I'm not sure that's really a question.
Yeah, I'm not personally familiar with what's happening in that particular field. Nothing is coming to my mind immediately. But that is only to say that Gerald perhaps may be thinking about it. And so I look forward to seeing that.
Yeah, and I think here I want to kind of insert a little bit too, is a lot of what you had mentioned about, you know, like some things being regulated under HIPAA and then some things being regulated under the FTC as like an app. So if you create a health app that is considered like health and wellness as opposed to a medical app, the medical app is covered under HIPAA, and the health and wellness app is covered under the FTC. And these are sort of different sets of regulations. And, you know, like with some of the, I think we're still working through what applies in each set. So, so that's to say, like, it's not always, since it's not, you know, like an FDA device or anything like that, the efficacy and like the evidence behind that is still questionable. And then another question from Gerald is around AI is evolving towards reliance, beyond reliance on data, towards the ability to create theories and models just like newborns evolve. And as this happens, we might see innovative cures or treatments currently challenging health conditions. What are the institutional barriers in adopting such machine-generated solutions?
I can try to take that too. I guess I think there's probably a lot. First of all, there's the financial barriers. Who is creating this AI and how are they selling it? So I think that's actually why you're seeing a lot of healthcare organizations working with you know, technology companies to develop it so they can be kind of in on it and it doesn't become a huge expense. But I think expense is one thing. I think another thing is risk, you know, risk exposure. So if they start to utilize an AI that's not well tested, that leads them away from what's considered standard of care, at the moment, they could potentially be held liable. So if an AI is suggesting one thing and standard is different and the AI is wrong and the clinician follows that. So I think there's some risk related issues that organizations are, and I wanted to get into that, but at least I could have said that right there that are relevant for organizations too, to think about. And I think also clinician uptake is part of it too. If an organization just throws something into the clinical realm and clinicians aren't using it, that's not going to help either. So those are some of the things that come to my mind, at least initially, related to some of the organizational challenges.
Right. And then as a implementation scientist, Kelly hit on all the areas when we think of implementation outcomes. So uptake, cost, acceptability, right? And so those are oftentimes the determinants of if an intervention, in this context, AI, is scaled up in an institution. And so just being mindful in how healthcare organizations are partnering with outside organizations when developing these models to address some of those determinants up front.
Yep. And the last question, it's more of a comment about the example of probability of death in a pediatric ICU. The physician has the same imputed data information that the computer has and should be able to determine risk. They should have additional subtle information that cannot be imputed into a computer. One risk is that the data can be used by hospital administrators to decide who should be transferred out. I don't know if you want to comment on that, Kelly or Faith.
Yeah, again, like we have to think about organizations as having a variety of different motivations. One of which is to make sure that they provide the best healthcare possible. And they also are motivated to maintain financial solvency. I mean, it's just the facts. And so if there is an opportunity to do that, they will explore it. And so we need to be thoughtful about the implications of that. And the point, there is a point in this question, though, around what the clinician can glean that an AI may not be able to glean. And I think that's like TBD, right? We don't really know. But why I would argue that the clinician is not going to be out of the mix here. And even if the AI is 1,000% accurate, we still need people like Faith and all the other clinicians out there to be helping people understand what is being shared with them and what the technology is saying and why. So clinicians are not going to be gone, at least not, I don't think in the near future. So I think it really is important to acknowledge some of those subtle importances and the organizational motivations. I
think the last one comment I would tack onto that, and we're past time, but it's just that there's a lot of data in the EHR. And so, you know, although the clinician might have access to the same data, you know, computers are really great at reading large sets of data and sort of synthesizing it. So I think that this is where that computer-human relationship comes in. So like we're really great at intuition and kind of reading, you know, is the patient really in pain? You know, like, does it seem like, you know, there's subtle cues that allow you to figure out, you know, how the patient is feeling that the computer can't, you know, doesn't have access to. So I think, you know, you're right. There can't be a separating of these two relationships. They don't act autonomously. Well, I want to thank you for the great conversation. You know, appreciate everything you guys are doing. And if folks on the call, if you have additional questions, please feel free to email iam@northwestern.edu, and we will be sending you a recording of this seminar as well. Thank you.